Good afternoon and welcome everyone to the impact of ACEs on breastfeeding among Black women. I'm happy to welcome you today and also partner with the WIC office in Sacramento to bring you a group of amazing speakers and panelists to talk about an important issue in the Black community. So today's webinar will focus on dismantling stereotypes, cultivating cultural humility, trauma-informed care, and addressing disparities in breastfeeding amongst Black women and breastfeeding behavior. So we've got a great lineup for everyone today and amazing speakers, as I mentioned, and I won't stand too much in between me and everybody else, but briefly, I am Rhonda Smith, the Executive Director of the California Black Health Network. We work to advance health equity for African Americans and Black immigrants across California. We're a 40-year-old organization, and we do a lot of work every day around outreach, education, advocacy, and policy to make all that happen. And so we've had the opportunity to work with the amazing folks at the office in Sacramento over the past few months, getting this event together for you today, and we hope you will enjoy it. And so I want to start by introducing someone who wears many, many, many hats, Dr. Tanya Khemet Taiwo, and she is an assistant professor at the Department of Midwifery in both the Master of Science and Midwifery program and the Master of Arts in Maternal Child Health Systems programs at Bastyr University. She also provides midwifery care on a part-time basis at Communicare Health Services, a federally qualified healthcare center with clinics in urban and rural communities. So she's had a lot of experience working at the community level directly with women in need. She lives in the Sacramento area and she's worked with many clinics in the area to really provide compassionate care to low-income communities in a multidisciplinary setting. And so I think it's safe to say that Tanya has this work in her blood and in her genes. She comes from a family tradition of midwives stretching back to at least 3 generations. Her grandmother and her maternal aunts were midwives practicing in rural Jamaica. Tanya's mother and her sisters and her brothers and great aunts have enjoyed traveling many country roads on dark nights accompanied by all of the seeing owls, and maybe she can explain a little bit more about what that means. But without further ado, I'd like to turn it over to Tanya Khemet Taiwo.
Thank you, Rhonda, for that lovely introduction, and thank you for your organization and all of the work that you do across the state of California. My uncles and aunts used to tell me how when their mother went to go to, woke up in the middle of the night to deliver a baby, they would always hear the owls, and so they always associated the owls at night with a baby being born. And yeah, I've worn many hats, which is true, and continue to wear many hats. I think a lot of us who do work in the community, who do work for our people, we do find that we wear many hats because there's so much work to do. But I think the one thing that is missing from my bio is that I breastfed 3 children. And I must admit that that was both the most rewarding and the most challenging thing that I've ever done in my life. So welcome to all of you for our panel on cultivating cultural humility and impact of past trauma on Black women and breastfeeding behavior. We have some amazing speakers for you, and they will be sharing their expertise and wisdom, and then we'll have some time for discussion. I could say much more about them, but I'll just give you a brief overview of who they are. We've got Aqueelah Russel, an international board certified lactation consultant and certified childbirth educator. Her background in community relations and marketing. She holds a Master of Business Administration and a certification in Human Resource Management. Currently, she is the Regional Breastfeeding Liaison for the Northwest Valley Health Corporation WIC program. Aqueelah also operates a private practice Nene's Lactation Consulting, where she provides support and empowerment for breastfeeding families. Aqueelah is the mother of 2 amazing breastfed children and 2 spoiled dogs. It is through her personal experience that she has developed a passion for the promotion of breastfeeding and believes that every drop is a gift. And we also have Tamesha Valverde, who is the proud mother of 2 breastfed sons, an internationally board certified lactation consultant and doula residing in Stockton, California. She's a 4th generation Stocktonian. And Tamesha has over 18 years of experience working with expectant and young family in the community, providing direct lactation services. The only African-American consultant in the San Joaquin Valley. Whew. I just have to say that sentence again. And it's both amazing for who Tamesha is and also quite sad. The only African-American consultant in the San Joaquin Valley, in San Joaquin County. She specializes in group education and advocacy for African-American pregnant breastfeeding women and their families. Additionally, for the last 3 years, she has been co-chair and host of the annual California Breastfeeding Coalition Summit and served on the planning committee and MC for the 2021 Black Mothers Breastfeeding Association virtual conference. She was also recognized in 2018 by the California State Legislature for her work with African-American women in San Joaquin County as a lactation consultant and health advocate in women and children's health. Aren't they amazing? Please join me in acknowledging these sisters, their accomplishments, and the important work that they are doing to support Black mothers. After we speak, as I said, we'll have time for questions and discussions. So welcome my co-speakers, and welcome to all of you who are here. Thank you for your commitment to helping our babies thrive. And before we move on, I have been asked to briefly discuss the science behind childhood trauma and toxic stress. So before I dive in, we'd like to know who's here. And so if you could answer the poll, and just tell us who you are. Okay, so giving everybody a chance. Gladys, I'm turning things over to you momentarily so you can let us know when folks have voted. And
sure, almost done.
And I do also want to say that, and Rhonda just put this in the chat, but if you have any questions, just put them in the Q&A space, and I will be reading the questions and giving them to the panelists. Okay, wow, we've got lactation consultants and lactation educators. Yay to you all and the work you do. We've got healthcare providers, and I'm sure of many types, and also community health professionals, the folks doing on the ground. And we've also got some birth workers. That is lovely. Welcome to all of you. All right, so I'm going to be talking about the science of ACEs and toxic stress. But first, I just want to know, how familiar are you with ACEs? ACEs is adverse childhood experiences, commonly referred to as ACEs, are potentially traumatic events that occur in childhood and adolescence. Okay, so we've got a lot of folks who are very familiar, good, and some familiarity and some first timers. So that's really great, and looking forward to having all different kinds of questions coming from people at all their various levels of knowledge about the topic. ACEs can, include experiencing physical, emotional, or sexual abuse yourself, or witnessing that kind of abuse, having a family member attempt suicide, or growing up in a household with substance abuse, mental health problems, or instability due to parental separation, divorce, or incarceration. So the first ACEs study was done by the Centers for Disease Control at the CDC and Kaiser Permanente in 1998. And since there, we've had more than 2 decades of research that has documented the association of these adverse childhood events with health and well-being across the lifespan. What we now know is that ACEs are associated with an increased risk for numerous negative outcomes, including a wide range of chronic diseases, and also is a leading cause of morbidity and mortality, such as cancer, diabetes, heart disease, suicide, and drug overdose. ACEs are, in addition to the health effects, which is going to be the focus here of our today, ACEs are also associated with negative effects on educational achievement and also employment potential. Importantly, the historical and ongoing effects of racism or poverty, living in under-resourced or racially segregated neighborhoods, and experiencing housing or food insecurity contribute to, these are the social determinants of health, and I'll talk a little bit about that, can contribute to and exacerbate the effects of ACEs. So let's talk a little bit about the science of stress. So right now, I'm feeling a little stressed. Also, the other two speakers are feeling a little stressed. Perhaps Rhonda is feeling a little stressed about how this presentation is going to go. This kind of stress, you know, and the release of adrenaline actually makes us a little bit more aware. It makes us more capable. It allows us to do a better job than we would have done. That's the good stress, right? And then, but then we also have toxic stress. That's the unrelenting stress of every day. Like if you don't know that your childcare provider is going to show up so that you can go to work, and you experience that every single day. If you got to search your house for the money to put gas in your car to get to work, that is what we call toxic stress. Or you may have heard the term allostatic load. A large and growing body of research indicates that the underlying mechanism by which ACEs are associated with health outcomes is through this toxic stress. It's a chronic activation of the stress response system. So the same response system that's acting in me right now so that I can do the best job that I can do is chronically activated in those people who've experienced adverse childhood experiences. It results in this dysregulation of what we call the limbic hypothalamic pituitary adrenal axis, elevating levels of catecholamines, which is your fight, which activates your fight or fight response, cortisol, which is our stress hormone, and pro-inflammatory cytokines, leading to cascading effects on the nervous, endocrine, and the immune system. These changes can affect attention and other executive functioning, how we make decisions, impulsive behavior, brain reward systems, decision-making, and our responses to stress throughout the lifespan. Well, none of this is new to us. We've got many, many healthcare professionals, many community-based folks in the audience. We know this, we've seen this, we've served folks who are experiencing this toxic stress. So we know that ACEs and toxic stress are new to us. However, the scientific understanding of ACEs and toxic stress allows us to map the pathways of these early life experiences and how they affect health, and provides a scientific basis for preventing ACEs. So I wanted to talk about the social determinants of health. And so we're talking today about adverse childhood experiences, but also remember that the folks who experience these adverse childhood experiences are also experiencing the social determinants of health. Joy Creer-Perry and members of the Black Mamas Matter Alliance published a excellent paper on the social determinants of maternal health. And I highly recommend that everybody read this paper they developed this framework called the web of causation, and looking at how all of these effects, how slavery gets us to poor maternal health outcomes, how redlining in our communities ends up with particular demographics, ends up with, you know, how community schools, poor schools, and all of these contribute to our healthcare. We know that just your neighborhood matters, where to your health. And so, okay, so let's dive into the data. So as I mentioned, we've had 20 years of being able to study ACEs. And one particular study that I like was done by the CDC. It was a phone survey, almost 150,000 adults across the country. And what they found is 61% reported at least one adverse childhood event in their lifetime. And 15%, that's a very large percentage of the of this country, reported 4 or more ACEs. And what they found is that the number of ACEs increased your risk for health risk behaviors, chronic health conditions, and socioeconomic challenges. So what we call that is a dose-response relationship. As the number of ACEs increase, your risk increased. So we're going to dig a little bit into this data. So what they did is they compared the people without exposure to ACEs, so no ACEs in there, no ACEs reported, and then they looked at the people who had 4 or more types of ACEs. And then they statistically adjusted for confounding factors like race, ethnicity, sex, age, and they found these increased health risks. So an adjusted odds ratio is a statistically derived measure of effect and gives us an idea of the odds of a particular outcome when a particular exposure is present. Okay, so for those folks who had 4 ACEs, when compared to those with none, their risk of having coronary heart disease was 80% higher. That's what 1.8 of an odds ratio means. Their odds of having cancer was 40% higher, double for stroke, almost 3 times for COPD, and 5 times for depression. So I just want folks to sit with that and just for a moment. These are very serious numbers, and this is a very large sample from across the country. So where we are now in California is that the California Department of Healthcare Services, in partnership with the Office of the Surgeon General, launched the ACEs Aware program, requiring all Medicaid providers training in the tools and resources for screening ACEs. And I'm sure many of the folks who are here have taken the ACE training. In this time, more than 20,000 California clinicians have been trained to screen, and more than 500,000 children and adults across the state have been screened for ACEs. So first, I'd like to acknowledge our Surgeon General for her leadership. Thank you, Dr. Nadine Burke-Harris. This screening has shown is that 62% of Californians have experienced at least one ACE. And the emerging data is showing that our current pandemic is leading to significant increase in ACE exposure for our current generation of children and youth. Another thing that we need to know about California is that Governor Newsom signed into law Senate Bill 428, the ACEs Equity Act, which significantly expanded coverage for ACE screening by requiring all health insurance plans that provide coverage for pediatric and preventative care to include ACE screenings. So as a result of that, we're going to find more and more people are going to be screened for ACEs, and hopefully more and more people are going to be getting the care that they need. Because it's not just about screening, right? We've got to screen, we've got to treat, we've got to heal. And so enhanced primary care programs such as this is one example, the Safe Environment for Every Kid, screens for ACEs and other risk factors in the family environment, and works with families to address these concerns. This program has demonstrated fewer reports to Child Protective Services and also better adherence to medical care than among similar families that have not been exposed to this intervention. Given the multi-generational effect of ACEs, screening parents for ACEs to implement primary prevention for the family could potentially help break the cycle of ACEs by providing an opportunity to implement protective and preventative strategies. Several screening tools to identify ACEs in children as parents, as well as to address resiliency. Social supports and protective factors are also available. In addition to the primary prevention of ACEs, clinicians in healthcare systems are important to reducing harms. By incorporating trauma-informed care and services, which is what our speakers will be talking about, and how this applies to breastfeeding, incorporating these trauma-informed care and services into clinical practice settings. Important elements of trauma-informed care include understanding how trauma affects health, routinely screening for ACEs, using culturally responsive both assessments and care models, promoting resilience and other protective factors, addressing trauma-related somatic, like embodied and also mental health issues, and then ensuring appropriate linkage to services and supports for identified issues. We should all realize that some patients who have experienced ACEs may not be achieving their optimal outcomes in their health due to the physiological and psychological effects of stress. Addressing the underlying trauma through strategies such as trauma-focused cognitive behavioral therapy may attenuate the effects of trauma and help individuals adhere to the treatment protocols, to adhere to what we say about healthy behaviors and achieve better outcomes. From a systems perspective, data sharing is critical. Co-location of primary care, behavioral health, and other services has been recognized for its efficiency of addressing the broad needs of families. This holistic approach to care is important, is particularly important for those folks who have experienced ACEs. We know from the data that ACEs are prevalent in the US population. We also know that they can potentially affect the health and well-being throughout the entire lifespan. Recognizing our role of preventing ACEs before they occur and implementing trauma-informed care to mitigate harms are key steps to reducing the health effects. The best available evidence points to a number of practical steps we can take. And importantly, these efforts should be pursued in tandem with comprehensive community-based prevention strategies that ensure a strong start for children, enhance the skills to help parents and youth handle stress, manage emotions, tackle everyday life challenges, and connect parents and youth to caring adults and activities to promote social norms that protect against violence and adversity, and strengthen economic support for families. All right, so one last word I'd like to say. I am an epidemiologist and a midwife, and I value the scientific method and evidence-based practice. But I also know that our people have many forms of embodied wisdom culture. Maybe some of you here have experienced the healing of gospel music that filled you with joy and euphoria when times were hard. In similar ways, the Orisha dances of the Yoruba people, both in Nigeria and in Cuba, the dances in Haitian voodoo, Bahian candomblé, and the all-night Nyabingi drumming of the Rastafarians all provided opportunities for healing and wisdom expressing in our respective communities. Black people have engaged in these ritual communal ceremonies across the diaspora. utilizing active methods of embodied healing, different from the theoretical book models that dominate Western traditions, right? Much of today's educational systems belittle traditional wisdom and refuse to treat such forms of knowledge seriously. Since colonization and the expansion of European imperialism, disembodied knowledge has dominated the American as the valued social paradigm. This is why ACEs, it took so long for science to discover ACEs. When our communities, indigenous communities, knew that this existed and they had healing, communal healing methodologies. So, but the times are changing and we are learning to combine the science with traditional forms of knowledge. Sometimes there's been cultural appropriation and without acknowledging, the roots of the wisdom. But we need to combine these in our work with communities. And we also need to pay attention to our own healing as well, addressing our own wounded child as we work to heal other wounded children. Thank you very much for your time and attention.
Thank you. Thank you so much, Dr. Taiwo. And thank you for setting the tone for this meeting and providing us such a great overview of ACEs. And I want to thank the organizers today for inviting me here to speak with you all. You did mention the stress factor, right? And no pressure, but there is about 160 people on this call today. And I think that this is amazing that you're here to learn about ACEs and the impacts on the Black woman and how it affects their breastfeeding behavior. So thank you all again for allowing me to be here and to share this space with you as we present about breastfeeding on this Friday afternoon. So you can go ahead and share my slides. Okay, so again, I am Aqueelah Russel, and I will be talking to you today about the disparities in breastfeeding and the impact of past trauma on Black women in breastfeeding. So I think we should just go ahead and jump in and get started. There are a couple of things that I do want to start off with. Next, go back. Too fast. I really want to uplift all of our Black mamas and the babies and families and recognize that breastfeeding is a major component in Black maternal health. It's not just about providing that nutrition to the baby, but it is something that will last their entire lives in terms of building their microbiome and hopefully eliminating a lot of health disparities that Black people face. I will use throughout this presentation breastfeeding because I am a breastfeeding mother. I breastfed my 2 babies, and it is something that I am used to. However, I will recognize and respect that there are other terms that are being used, such as chest feeding, body feeding, and human milk feeding alike. So whatever your terminology is, please make sure that you also include that when working with your families to understand that we all do not breastfeed. I also believe that it is really important to present utilizing evidence-based research. Excuse me, I have a little bit of allergies going on today. Evidence-based research. However, I am very passionate about breastfeeding, especially because my children are both really young, and it's just been such a wonderful journey that I've been able to experience with them. So a lot of what you will hear from me today has a lot of my personal experiences and stories engraved within. So I really hope that you guys like storytelling. Also, be open to understanding differences, right? We are all impacted with what goes on within our communities and people alike. A lot of times these conversations are difficult to have. Sometimes you don't want to hear them. Sometimes you've heard them way too much. But just understanding that just because it's not a problem to you, I say this all the time, doesn't mean that it's not a problem to someone else. And so again, kudos to everyone that's on here trying to learn more today. And lastly, I have no disclosures. Before we move on though, I always like to incorporate some type of personal aspect into my presentations. This photograph that I selected here is really important, and I think it really helps us get our points across in showing 2 things. One is that Black moms do breastfeed, right? You see here we have this beautiful Black woman breastfeeding her first baby. And 2, there are Black lactation consultants in the field. So this picture embodies both of those aspects and the beauty of us working as a village to help our mothers provide human milk to their babies. Next. So of course, in any good presentation, you gotta put some data in there. I will only highlight 2 data points within this survey that was from 2019 and 2020, is that 83% of infants were ever breastfed, and that is across the board in any race. And according to the American Academy of Pediatrics, the goal is for our babies to receive breast milk for a minimum of 6 months, and only breast milk. I think this is important to also know and identify when working with the African American community and our ancestors, our mothers, our mother-in-laws. This might be difficult, right? I know for me and my mother, who has 11 children, breastfeeding for 6 months and not giving anything else was just not happening in my household, right? I had my son, and at 4 months, he was sucking on a rib bone because my mom thought it was absolutely fine. And, you know, maybe so. But just knowing that there are differences in cultures that will affect some of these rates. So just knowing your population and your community is certainly helpful. Next. Okay, so healthy people, the 10-year plan. So the 2020 breastfeeding objectives. So fewer non-Hispanic Black infants at 75% are ever breastfed, compared to Asian infants, who actually have the highest numbers at 92%. And then white and Hispanics come in at about 85%. So in the next 10 years, the goal is to raise that number from 25% to 42%. This certainly seems like something that's doable, but also keep in mind that our Black breastfeeding rates are already behind. So we have a lot more work to do, specifically in the African American community, to get us to those 2030 healthy people objectives. Next. So I'm gonna be honest with you, I am not a data person. I do not love numbers, and I do not typically incorporate them in presentations, but I do understand that they're important. But how important are they, right? So when we're looking at breastfeeding gaps, I personally think it's very important to understand the community voice and to understand the narrative. What is going on, not just the numbers, but what is going on to cause our Black moms to not offer human milk, mommy's own milk, to their babies? Where are those disparities happening? Where are those gaps? It is the way we interpret the data that will allow us to figure out where we need to move the needle. So my husband, who works in finance, he always says numbers don't lie, but there's certainly a way to skew that data. So I'll give you a brief example, and we'll use money, because everyone knows money, loves money. So if you were told by your banker that, Mrs. Johnson, you've lost 1% of your money or 10% of your money, you might say, okay, it's just 1%, 10%, that's not that bad. But what if that 1 or 10% equated to $1 million? Now you're listening, now you're like, where's my $1 million? What's going on? And so basically what we're looking at here with, it's about, I'll use basic numbers, a 10% difference, actually 12, between the disparity and the gap of Black and white breastfeeding. So if you really look at it, it's about 1.2 million, roughly, of the difference of Black babies who are not receiving breast milk in regards to their white counterparts. So that is something for us to really all stand and take note of. I will share these photographs at the top with you, and this goes back to understanding the narrative and not just the numbers. I am currently working on a photo voice project for some deliverables for a grant. And here are some photos that our moms within my community have provided to show, one, the beauty of Black breastfeeding, and to also share their journey of breastfeeding through images and not just a survey or, you know, a tick sheet or something like that. So I think that this is really important for us to grasp and understand the journey of the women, mothers, and families in which we're trying to serve. All right, so what is causing these gaps? And I've heard people present all the time and just blatantly say it, it's racism, right? And rightfully so, yes, that is the case. So let's talk about systemic racism. I will define it because I don't want to assume that everyone knows about it. So it's also known as structural or institutional racism, when systems, processes, procedures are set in place that put African Americans at a disadvantage. It's also a term that refers to a form of racism that is embedded in the laws, regulations of a society or an organization. It manifests as discrimination in areas of housing, healthcare, education, and political representation. So to me, that's life. That's in every single part of our lives. We cannot escape it, right? And so let's talk about who's on the call today. I know everyone listed where they're working, what they're doing, which is great. So it gives us some context to know who we're talking about. And I ask you, what assumptions are being made about the desire to breastfeed? For all the providers in the room, just quietly take a moment and think to yourselves, when someone is sitting on the table or coming into your office for support, have you already made assumptions of their ability, what they want to do, what their babies deserve, or any other implicit biases that you have put upon this person? Really think about that to yourselves. Who is more likely, in your opinion, to breastfeed? Is it someone that looks like me? Or is it the person that has come into your office who is working full-time, who has a husband that also works, who's educated, who has access to a doula, lactation professionals? Or is it the mom, the Black mom, who's on her 5th child, she's a single parent, and she is receiving government assistance, right? Are you equating all of those to her ability to breastfeed? And these are things that you really need to start asking yourself. I know my other presenter is going to talk about stereotypes, so I won't really get into that too much, but what stereotypes are you placing upon that mother and her desire to breastfeed? So we can't talk about all the things that are going wrong without having some action items. I am so big on this. We come to so many meetings, so many webinars. Zoom is like the thing, but what are we going to do? It's time to take action. It's time to stop talking about things. I know that we are all doing some form of implicit bias trainings, sadly, because of all of the horrendous things that have happened to the Black body and Black people, not just in the last 2 years, but for hundreds of years, right? Senate Bill 464, the Dignity in Pregnancy and Childbirth Act, is mandating for providers to take implicit bias training so they can understand and learn how to unpack it and leave it at the door, right? And help the people that are coming to you that you are supposed to support. Cultural congruent lactation support. And what I mean by that is, here's another definition for you. When you integrate the beliefs and cultural values of people, families, and communities with the views of a multidisciplinary team of healthcare providers. When you provide culturally congruent care, you bridge cultural gaps to provide essential and supportive care for all patients, regardless of race. So what can we do? We need to start uplifting our aspiring lactation professionals. I know here, I live in LA County, and our breastfeeding task force, which is Breastfeed LA, is doing a phenomenal job in that work with providing lactation education courses for aspiring Black lactation consultants. I know, Tamesha, you are the only lactation professional in your area. In LA County, I think when I first started, it was about 1% to 3%. Now I think we have moved the needle up to 5%, so woohoo, right? But 5%, who's the other 95%? We certainly don't make up 5% of the population. And so there needs to be a lot of work. Diversity in the workplace. So if you are not working from home and you are at work, take a quick look around and see who are your coworkers, who are the doctors, the lactation consultants, the nurses, the front desk personnel, anyone that's in your building that's affecting or coming in contact with the breastfeeding dyad or family. Are they diverse? Do they represent the community in which you are serving? And I do want to be clear that diversity does not necessarily equal equality. So you can have other people within your office, but are they mirroring and reflecting the people in which they are serving? And I will certainly age myself here with this, but FUBU, if anyone knows this popular clothing company from the 90s, which stands for Us, By Us. and also the saying of nothing for us without us. And so that's the way we are, you know, as Black women, as Black individuals, people. We thrive in our environments with the sisterhood and feeling comfort with being, you know, cared for by people that look like us and that understand us and possibly are not judging us based on locks in our hair, the way we speak, or the, you know, the swagger in our steps. We also need to incorporate Black families in bodies of research and study. I know there's a lot of talk surrounding this right now with COVID-19, the vaccine and things like that. How many Black folks were included in the studies, right? That's a question that's always being asked. So it's not just with breastfeeding, it's with so many other things that we need to start incorporating more Black families and individuals in our studies. And I mentioned this, but increase lactation support. And when I say increase lactation support, I mean free lactation support. WIC does not only service all the Black people that are in the area, right? There are Black folks that do not qualify for WIC based on their income, you know, maybe slightly over, maybe greatly over. But I know that in my area, the going rate for a private practice lactation consultant is $300. And that's a lot of money. It's good if you're in private practice, but that's a lot of money for people to pay out of pocket. And so if you don't have $300 extra, or you don't even have food to put on your table, you're going to forego that support that can make the difference of whether or not you're going to exclusively breastfeed your child or not. We know that resources are known to be limited in populations that have a higher percentage of Black individuals. Now let's talk about the impacts of past trauma on Black women and breastfeeding. Next slide. So in order to understand the future, we certainly have to understand the past and present trauma that has been inflicted upon the Black woman's body. Wet nursing, we all know what this is, right? This is when Black women were forced to breastfeed their slave owners' children to the detriment of providing actual nurturing care to their own child. The benefits of breastfeeding were understood way back when, and the slave owners certainly wanted to have their children receive the best. What was happening was the slave owner's slave's child was being malnourished or even dying because they were not able to provide that own nutrients, those own nourishments to their own child. So stress, again, this is not the stress of being in traffic or running late to work, as we talked about with the first speaker. It's not trusting the system. It's not trusting healthcare providers, police officers, the very individuals that have been sworn to protect you. This is kind of a very dramatic example that I will give you, but it's something that happened. And again, I'm all for the narrative. I worked with a mom in private practice, and she decided to give birth at home, which is great, which is beautiful, but she gave birth at home because of resources. The entire pregnancy, her husband and her mother-in-law did a lot of research on home births and delivered her child at home. Now, I know this has taken place a lot in the past, and my midwives are probably like, oh my goodness, but she felt that she was in better hands, that her life was safer than going into the healthcare facilities. When I saw her, it was 2 weeks later. The baby had a tongue tie and some other feeding issues, but she didn't get that hands-on lactation support that she could have received in the hospital immediately after birth, because she simply did not trust that they would take care of her. Racial injustices, certainly, right? We all face it if you are African American or Black. For me, raising Black children is always a constant in my mind is, are they going to be okay? Are they going to be taken care of? If I have to seek medical attention or help for them, will they get it? This is something that we always have to see because of the news outlets, social media, it's always in our face. I just got a 5-minute warning, so I'm gonna rush through this. Generational trauma, I like to think of this as things that are ingrained and stained in us. Vicarious trauma, even though a lot of these things I didn't face myself, I hear it all the time, right? And so I wear it all day. So negative expectations are being set for a joyous birth and breastfeeding experience because we've heard so many negative stories. Rising levels of certain hormones such as cortisone, stress, can dramatically reduce a milk supply. So epigenetics is our nutrition, chemical, stress, emotional experiences. These are things or tags that can go with us for 10 generations. Certainly, maybe even stemming back to things that we've experienced in slavery. There's been research done. There's a great study done on Holocaust survivors and their children. They're children of Holocaust survivors and the stressors that they face, which can lead to heart disease, obesity, diabetes, and brain conditions. So the maternal environment during pregnancy and the infant's first received nutrition impacts the epigenome significantly. Breast milk can potentially change the epigenome to affect the lifelong health of the infant. And with that being said, we're known to have so many health issues in our lives. So breastfeeding hopefully can help eliminate some of those or reduce the risk factors. Breast milk should be the first food. We're seeing a lot of breastfeeding end in the Black community before it should. There's a lot of introduction of artificial baby milk in the hospitals by providers. There's lack of visibility, going back to having Black lactation consultants, and there's more access to free formula versus free lactation support. So some of the implications, if you don't know, breastfeeding can help reduce the occurrences of breast and ovarian cancer, reduce diabetes. For babies, premature babies specifically, Black women are known, not known, but have a higher risk of delivering premature for a lot of those risk factors that they have to face on an everyday. And so supplementation oftentimes are recommended. Also, Black babies also have a higher instance of being born with low birth weight, which could lead to devastating disorders such as necrotizing enterocolitis, which could be prevented by receiving mom's own breast milk. And this one, I just want to quickly highlight because I think it's so important, and I'm seeing this way too often, is moms are being put on contraceptions to slow down their fertility. Black women are always seen as being extremely fertile. And so doctors will try to help them from getting pregnant again, but they're introducing contraception way too soon, which can definitely have an impact on a mom's milk supply. And so with all that being said, the Black woman's body is certainly guarded. We have documented years of historical trauma, all in the name of the advancement of gynecology. Our bodies are considered a source of wonder for exploring, poking, and prodding. And for some odd reason, they have the notion that we do not feel pain. I certainly feel pain, right? We are stronger, tougher, and more resilient, but we do feel pain. Breastfeeding can reduce many of the health risks for both mom and baby. So here's a few reminders. I will close because I know they're counting the time. Breastfeeding is the optimal feeding choice for all infants, Black, white, alike, all babies. So stay informed. The term on the street is stay woke, right? Understand that these are things that are taking place in your community. Check your own biases. Start to ask yourself these questions. Start to ask these questions of your bosses, your coworkers, anyone affecting the dyad, and do not be a bystander. Do not stand by and watch injustices and inequalities take place within your institution. Remain aware that Black individuals are not always granted the same level of care and support by healthcare providers. And care should be provided through an equitable lens with the understanding that disparities in breastfeeding do exist, and the impact of past trauma on the Black woman can certainly impact their breastfeeding behavior. So thank you so much for your time. I hope that you guys all have a great weekend, and I've provided my contact information. If anyone would like to further the conversation, I would be more than happy to do so. Thank you.
Thank you, Aqueelah. I'm here clapping. And I hope other people in your virtual spaces that you're also clapping that excellent presentation. And now I'd like to turn things over to Tamesha Valverde. And Aqueelah, please read the chat. There's all kinds of accolades coming at you in the chat box. And also a reminder, loving what's happening in the chat box. We all of the speakers as well as the organizers really appreciate it. But also please post your questions in the Q&A. There's a little Q&A link right beside the chat. And so we're looking forward to having a discussion with you all with questions that are coming up. All right, Tamesha, turning things over to you.
Thank you so much, Dr. Taiwo. Oh, wow. Aqueelah, I just want to say thank you actually to both of the presenters that went before me, because you really set up stage for me to come in and talk about the topic that I was charged with for this this afternoon. Aqueelah, your explanation of racism and your calls to action line up exactly with what I'm going to share in my presentation today. And I want to say thank you for the shout out for the need for more lactation consultants, aspiring Black lactation consultants to be supported in our communities. So thank you again for the opportunity to be able to present today. My name is Tamesha Valverde, and I'm a mother, a lactation consultant, doula, and advocate in my community. And I don't take what I was charged with lightly. Today, I'm going to talk with you about moving from competence to humility and changing the mindset to better serve Black breastfeeding families. So really, this is about dismantling stereotypes and cultivating cultural humility. And before I move forward, I just wanted to say thank you to the organizers that put this webinar together and for the opportunity to talk about this and bring light to the community that I am so passionately serve. So my hope is that by the end of this presentation, you will have gained a clear understanding of stereotypes and cultural humility. You will have identified some common stereotypes and how they play out in Black breastfeeding care, and also learn ways of how to start your own personal journey in applying cultural humility when you're working with Black breastfeeding families. Oh, well, there was a slide prior to that that just said that I don't have any conflicts or disclosures. The only thing that I will say is that I am a Black woman, so I will be talking from my own personal experience and perspective, and I am the mother of 2 amazing young Black sons that were breastfed as well. So that also shapes my perspective. So before we get really started deep into this topic, I want to just make sure that we have a clear understanding of definition. So in order to have a clear understanding, we need to define things. So stereotypes. Stereotypes are defined as beliefs about characteristics, attributes, and behaviors of members of certain groups. Okay, so beliefs are our values, our truths, what we would consider, not necessarily the truth, but our truth. And it's what we would consider to be true. And some characteristics, examples might be intelligence, or considering somebody to be considerate, or if they're honest or dependable. And then behaviors, what they do, the actions. So I'm going to show you just kind of a little example. You may perceive or believe that a certain individual is inconsiderate or not dependable. And because you perceive that, then you might assume that if you put on an event that they're going to just show up late because they're inconsiderate and not dependable. So that's an opinion and your belief of that individual. But when you take that and you apply it to a group of people and you make it a generalization, whether you know that individual or not, that's when it becomes a stereotype. And stereotypes are not necessarily the truth. So how does this show up in healthcare? Well, there's a lot of evidence that healthcare professionals consciously and unconsciously hold stereotypes, and that can lead to discrimination in both provision of care and healthcare outcomes. And I know Aqueelah kind of touched on some of those. And I just want to say that she mentioned that these are things that take place in every area of our lives, right? So why would we assume that breastfeeding would be the exception to that? It is not. It absolutely is not. So stereotypes do play a role in breastfeeding outcomes. So where do stereotypes come from? What are the sources? These are the things that actually influence our core values. So sources of stereotypes come from mentorship, so our direct relationship with those that we learn from. So that could be our grandparents or our ancestors, right? It could be, so it's generational. It could be educators, those that are professors that we learn from when we're go to college or go to school. So our mentors, the people that teach us. And then there are peers. So there's peer-to-peer relationships and role modeling. You know, the saying that birds of a feather flock together. So what's acceptable in your social group with your peers is another source of stereotypes. And then we have media. Media is what we see, and that's that dominant narrative that social media and media outlets portray. And that's what we see, and it shapes how we look at things. So the example of this is, and I'm just going to kind of go briefly because I want to make sure I'm honoring time. But there was a study that was done in 1939 by Clark and Clark, where there was 2 dolls that were placed side by side. There was a white doll and a black doll. And you probably have heard of this study before. And what they did was they asked a series of questions to children, and both black and white children actually had similar responses. And they had more favorable responses toward the white doll and more favorable and less favorable responses or negative responses toward the black doll. And this study actually has been repeated over and over again over the last 60 years, and the results haven't changed. So when I was looking at that, I said, why is that? What's going on in our society that this stereotype or opinion hasn't changed and it's still continuing to be perpetuated? And we now know where stereotypes come from, but how do those stereotypes play out in Black motherhood and breastfeeding? So the next slide, we're going to discuss that a little bit. Next slide, please. So these are some common stereotypes. There are 4 main prevalent images of Black women that are widely known, and they date all the way back to slavery. We had the mammy, who is considered the unattractive Black mother who is strong and content in caregiving for children, oftentimes neglecting her own, in service, in servitude to white slave owners or even white employers. And then we have the sapphire, who is the aggressive, dominating, angry, emasculating Black woman. Then the Jezebel, who is immoral, sexually promiscuous, and sexually available. And then the most recent archetype or image of Black woman is the welfare queen. And that is, can also be termed as the breeder. We look at them as uneducated, poor, single Black woman who does not want to work and has multiple children just so that she can continue to take advantage of public assistance. Next slide, please. Next slide, please. Oh, previous slide. So we're going to go into Black breastfeeding myths and stereotypes. And there was a previous slide, but that's okay. I'll kind of talk a little bit about one more slide. Are you fixing it? I'll keep talking. So according to, there's a researcher named Susan Fisk, and she did some research on, well-known researcher on bias and stereotypes. And she says that we welcome people who we see as warm and competent, and we snub those who we view as cold and inept. And so that, so that is an example of the doll experiment, right? So I want you to think about that, so that we welcome those as we see as warm and competent and snub those as we see as cold and inept. And thinking about the doll experiment, I invite you to keep this in mind as we explore these common myths and stereotypes about Black motherhood and breastfeeding. And I also encourage you to do some self-reflection along the way as we talk about them. Next slide, please. Okay. So this is the first myth, and you heard it earlier. Black women don't breastfeed. So when we take this perspective, a stereotype, and we put it into action, it might look like, and we might not necessarily say Black women don't breastfeed, but we say that subconsciously or unconsciously, and then it translates into, you know what, I'm really not going to work harder than her, right? Why would I take my time to show up and do this work with her when she's not really, Black women don't really breastfeed anyway. Myth number 2, Black women don't exclusively breastfeed. So if she does choose to breastfeed, just one bottle of formula isn't going to matter, right? She's going to bottle feed anyway when she goes home. So that might be how that stereotype plays out. But the truth of the matter is, if you go to the next slide, you'll see that according to the newborn screening in hospital data in California, that 87.3% of California, Black women in California actually breastfeed. That's 2019 data. So 87.3%, and of those 87.3%, 61.6% actually exclusively breastfeed. So do Black women breastfeed? Do they exclusively breastfeed? Yes, absolutely they do. And I bet you that if they were better supported, that we would have more exclusivity. Next slide, please. The slides aren't advancing. Yeah, one more. Okay. So myth number 3. Black women are uneducated. So how does this play out? How does the stereotype play out? Well, she doesn't know any better. She does. I know better than she does. I am the expert. So she doesn't know as much as I do. So I should be able to make those decisions. And sometimes we don't necessarily say, well, they're uneducated, but we definitely take the position that we know better. We're the expert. Myth number 4, Black women are strong. And I know Aqueelah touched on this, but the belief that they have a higher pain tolerance and so that she can handle it. I don't know how many moms that end up in my office at outpatient for outpatient support where they said, you know what, I did say that my nipples were hurting. I did say there was pain, but it was like, oh no, it's okay. That's how breastfeeding is. So there's this misperception that, you know, pain early on in breastfeeding is normal, right? And she can handle it, right? Because Black women, we're strong, and we have a higher pain tolerance anyway. Next slide. So the truth of the matter is that Black women are not only educated, but as of right now, Black women actually have the highest enrollment rate in graduate school in the country. So they're not only educated, but they're also pursuing higher education. So that's the truth. Also, the medical lie, it's a long time medical lie in medical literature that Black women or Black people have a higher pain tolerance. And that is absolutely a lie. We do feel pain because you know what? We're actually human and humans feel pain. So completely debunked, right? Next slide. Myth number 5, Black women are single mothers. Dad isn't around to help anyway, so bottle feeding may be easier for her, right? She doesn't have the support when she goes home. She doesn't have the you know, it's going to be difficult. So, and dad's not present. Myth number 6, Black women need public assistance. I'm sure she's on Medi-Cal and WIC. And you know what, I'm going to give them the help that I can right now, but I'm just going to go ahead and refer her to WIC. And I'm going to give you an example. I've worked for the WIC program for the last 18 years. That's something I did not mention. And I work with hospitals all the time. I got a phone call where all the time I got phone calls about moms needing pumps, especially during the pandemic. So I had a phone call from a nurse that said that I had a family that, you know, needed a support from WIC, needed a pump from WIC. And so I called the family and come to find out that the mother not only didn't qualify for WIC, but she had a combined income with her and her husband of about $10,000 a month. She's a truck driver. She had private insurance. So not only didn't she qualify for WIC and couldn't get a pump through the WIC program, but she had all that time she had a baby in the NICU, and she's waiting to get a pump and figure out how to get a pump. And the nurse could have helped her just by asking those questions. Now, I'm not even going to tell you what her race and ethnicity is. You can probably guess. But is that prejudice and bias, stereotypes playing out in care? Absolutely. Next slide. Truth is, Black fathers are present, and they're also present in the home. And even if they're not present in the home, they're co-parenting, and they need to be included in education, and they need to be acknowledged. Majority of welfare recipients actually are non-Hispanic whites at about 43%, and non-Hispanic Blacks are only at about 23%. So you can see that Black families are not the ones that are accessing welfare services. Next slide. Black women are hypersexual. or overly fertile, right? Well, how does that stereotype play out? They need to be put on birth control immediately. Aqueelah had said it earlier, and we know that that affects milk production. Myth number 6, Black women are angry. She's just angry and emotional, and I'd rather avoid her. I don't want to have to deal with that attitude, right? Next slide. The truth is that Black women actually plan births. Yeah, they do. They intentionally get pregnant, and it's not because they want more welfare. It's because they want to have, baby when they want to have a baby. Some women even suffer from infertility, and so that's something that is the truth. And then as far as anger, Black women, I'm just going to say this: we have a right to be angry. We have a right to be angry. Anger stems from oppression and having to carry the weight of self-advocacy continually. We have the right to be angry. But is that our truth? Is that our existence? No, it's not. We're human, and humans have varying emotions, and there's complexity in our varying emotions, especially during times of vulnerability. And how much more vulnerable are you at a time when you're bringing your child into this world, right? So if she might be perceived as angry, it might be some of the layers that Aqueelah was talking about with past traumas that she's dealing with, trying to be a good mother and trying to birth. Next slide. So with that, I'm going to touch on cultural humility and what it means to really be humble. I was going to have you just drop in the chat, and I'd love to see it, what your definition of humble is, or humility. So if you have a moment, just go ahead and drop that in the chat, and I'd like to see those pop up. But because of interest of time, I'm just going to keep moving on. And so know that that humility is really defined as having or showing modest or low estimate, a low estimate of one's own importance. So in some, humility is, it ain't about you, boo. It's not about you. Stay humble. Yes, I see opens to other perspectives, opening your ears more than your mouth so that you can learn from others. I like that. I absolutely like that. So know that cultural humility is a lifelong process of examination and self-critique, where an individual not only learns about another's culture, but also starts an examination of their own beliefs and cultural identities. So it's a little bit deeper. So knowing the difference, we got cultural competency, reflexivity, and cultural humility. And the goal of cultural competency, which is a term that you probably have heard before, is to really just learn about another person's culture and needs, values, and beliefs. Reflexivity is really just taking and exploring your own personal beliefs, but cultural humility is doing just that, a combination of the two, but as a lifelong process. It is a process. Next slide. So that's the first step. You need to know the difference. The next step is awareness. Awareness, so this is where you do the work. You have to be aware of your own values, your own beliefs, and yes, your own bias. But simply being aware of stereotypes and biases does not change your behavior. You really have to understand that racial prejudice is a habit, and it is unconscious. It can be unconscious. It can be intentional too, but it can be unconscious. And in order to break an unconscious habit, you have to become aware and you have to be intentional. So you need to ask yourself questions like, who am I when no one is watching? What influences my decision making? And even what are my limitations, right? So awareness. The third step is doing your research. So, you can know the difference, you can become self-aware, but then if you don't have a foundational understanding, which I'm so proud of all of those that are attending today, because you are doing your research, right? understanding the systemic and historical factors are so important. Understanding that healthcare professionals have a history of not listening to Black women and operating in assumptions, including their own bias and stereotypes, and that historically the Black community does not trust the medical system for various reasons, and there are also at a greater risk for health disparities. So we need to call a spade and recognize that even the effects of slavery we're still dealing with. And just so you know, just to give you perspective, fourth generation, I told you Stocktonian, right? Well, the generation prior to that, my great grandmother's generation she was a slave, and my mother tells me the stories. And so I just wanted to just give that perspective. That wasn't that long ago, wasn't that removed. Next slide, please. Last thing is, don't just talk about it. I need you to be about it. We need to learn from our past so that we don't make the same mistakes in the future. And we need to know that historic and systemic, I'm sorry, I'm Russian, reasons for mistrust need to be excavated. You know, you cannot put a Band-Aid on a wound, right? It needs to be visible. You need to dig that thing up. We don't trust people enough with their own lived experience. We say autonomy, but what we really truly mean is autonomy with our permission, right? You get to have your permission, but true autonomy doesn't need permission. I get to have autonomy over my decisions as a mother, including breastfeeding and how that plays out without your permission. I don't need your permission. And here's the other piece, is that the answer is definitely within the community. And the community knows what it needs. The community, I'm gonna say that again, the community knows what it needs better than you know. And that goes for any community, but especially the Black community, given the history that we've shared with you today. Next slide. So with that, here's some application, some things that how you can apply cultural humility to supporting Black breastfeeding families. So the first thing I mentioned already was ask the community. So how does that happen? What kind of things can you do? Well, how about focus groups? How about having a roundtable? Like my organization, Flourishing Families, we do red roundtable talks where we talk to moms in the community and give them opportunities to share their experiences. Know your role. Know when to refer when it's out of your scope. You're not the expert of everything. And I don't understand why we know when to refer. Like, for example, when I have a baby with a tongue tie, I know to refer out because I can't clip that tongue, right? But sometimes even with culture, know that it's out of your scope and that's okay. So refer appropriately. Why? Because you're not the expert. And sometimes when you try to do things and you're not the expert, you can do more harm than you can do good. And then create safe spaces. Spaces where Black women can talk to other Black women. That's where some of these support groups happen, right? I know a lot of WIC support groups have had Black breastfeeding groups specifically led by Black peer counselors and Black lactation consultants to support them. Those are safe spaces. Why? Because we can talk in a different way and communicate in a different way amongst ourselves without judgment, with free of bias and free of concern, and be transparent with each other. I use a group facilitated curriculum called GPS, which is group peer support model. And what it is a trauma-informed group support model. And in that space, you're not allowed to give advice unless asked. You're not allowed to interrupt. And it's a judgment-free zone, and ladies know that. What's said there stays there. And so those things are super important. So with that, additional things to think about is supporting equity efforts, policies, legislation, workforce, like Aqueelah mentioned, and then positive images in media and everything that you do. If you notice throughout my presentation, there have been beautiful pictures of women these are women from our community here in San Joaquin County that are breastfeeding. And just my call to action, in my county, we actually have 3 aspiring IBCLCs, and they're pictured here. And so hopefully by this time next year, I will not be the only African-American lactation consultant here. I want to leave you with a quote, something that actually I say a lot, and that is a mother may nurture her child to grow, but it takes a village to make them flourish. And I know that we all have our own roles and our own perspective, but I want you to remember and understand that when you understand, you know, and you operate in your role, you become a vital part of a Black mother's village and her breastfeeding experience. So I want to say thank you for taking the time.
Yes, thank you, Tamesha. That was fantastic. And I hope that you can scroll through the chat so that you can see all the love that people have been typing throughout your presentation. Thank you, thank you, thank you. So I would like to ask my fellow speakers to unmute and show themselves again. And then we're gonna dive into the questions. And I'm hoping that with Tamar's help, that keeping us on target, that we can get through all of the questions. Let's see. We've had a few questions about how do I become a lactation consultant, and I think someone mentioned Santa Clara, someone mentioned LA, so I'm wondering if one of you can speak to the process.
So I think it depends on where you are. I think one of the first steps you should do is check to see what your local coalitions have going on. I know here there is a course, and I don't want to butcher it, but it's the Black course that is taught by Black lactation consultants. For me, I received my education from a Caucasian teacher who was absolutely brilliant, I will say. She was great, but it was through the lens of a white woman. And so pretty much a lot of what I learned was through her lens, right? With her own biases and things of that nature. So there's so much to becoming a consultant. Get my information and I can have a one-on-one conversation with you, because there are clinical hours that you will need. There is the educational piece that you will have to have, lactation specific educational courses that you'll have to take, and you will have to sit for a board exam that is about 4 hours, where you can demonstrate your competencies to provide lactation care to the dyad. So there's about 3 big steps that you have to take, but they are well worth it, especially if you want to support your community. That's the quick and dry answer.
It is, and I just want to kind of add to it a little bit, if that's okay. There's some resources, iblc.org, you can go to, and you can actually see what pathways that you may qualify for that. And then also, I don't know if you're familiar with Nikki and Nikki, but Nikisha actually has done a presentation through the California Breastfeeding Coalition on the last summit, where she actually broke down like how to become an IBCLC. So you're welcome to email me and I can get that resource to you, because it was a really informative presentation and really just kind of broke down the process, because it can be pretty tedious.
Good. And if either one of you could share how to, in Los Angeles, we have a specific question regarding Los Angeles, or maybe if there's anyone in the audience who knows about how to get in touch with Breastfeed LA.
Yeah, go to their website, breastfeedla.org, and look up their courses. I know that they're taught all the time. It's virtual right now, so you can be pretty much anywhere and take the class. And this is what we're talking about, cultural congruency. And the courses are being taught by women of color, which is great. And they do everything through an equitable lens.
Right, thank you both. We also have a couple of questions about making the slides available, and I think I'm going to ask Tamar if you can reach out to each of the presenters and see if they can make their slides available, and then send that out. So Tamar, if you because I don't want to put anybody on the spot right now here about the slides. So yeah, Tamar, if you can reach out to all the speakers and see if that's possible. So there's also a question about, are the topics of equity and structural racism incorporated into the ACEs framework, and specifically into the training given to providers? And Aqueelah or Tamesha, would you like to grab that, or I can take it as well?
I think you know so much about ACEs and that framework. So if you're willing, go ahead.
Yeah, so that's a really good question. I would say yes and no. I felt that the training was the ACEs training that I took. I thought it was excellent. I thought that there was definitely some work that had gone into equity and cultural humility, but not to the extent that Tamesha talked about, not to the extent of really addressing structural racism and not really challenging me as a person taking the training to address my own biases, my own stereotypes. And so, yeah, after, as I was going through the course, I was both saying, wow, this is really good that they addressed that, and like, oh, wow, they didn't go deep enough. And so I think that there's a lot of work to be done, and that Tamesha spoke so eloquently about. Okay. Yeah, here's a great question about ways that we can support fathers in the breastfeeding journey, how to support fathers to aid mothers in the breastfeeding journey.
Do you want me to take it? So one of the things that I think having the understanding that they are there to support their families, right? Like that they are part of the mother's village, and oftentimes they go ignored. And so I think just acknowledgement that they are present, whether they're in or outside of the home, and then giving them opportunities to be a part of the conversation, connecting them with resources in your community as well. So don't just educate the mom, but also educate the father. So I'll give you an example. With Flourishing Families, we did an outreach event, and we had a sister circle. And in the sister circle, the mother and the baby were being fed. Let's just say it that way. They were being fed, right? But there was dad that was standing outside of the circle. He had come to the event, and he was completely disengaged. So I decided to step out of the circle while it was being facilitated by the peer counselors to really talk to dad and see how he's doing. And then our support people were there too. So we had our partners there, and our guys were over there talking. So you know what I did? I connected him with them and let them know some of the things that he might need to know as a father, right? Some of his concerns that he shared with me. And then there was this mentorship that happened. And then I took a step back and I kind of looked and said, mom's over here and baby are being cared for over here, and dad's over here being nurtured as well. This is what the village is supposed to look like. So the reason why I'm bringing that up is because oftentimes we don't look at the holistic perspective of the village, including fathers. So we think that there's like some magic wand, some magic phrase that we say to include fathers, but it's really checking our, like we talked about earlier, our biases, and saying how can I be more approachable? What can I do to support them? I hope that answers the question. So, okay, I see someone said yes, that was good. So I really hope that answers the question, but you just need to make sure that you're including them. I know Rogue, Reaching Our Brothers Everywhere, does a really great job. They're based out of Atlanta. And I just did a webinar with Wesley Bugg, and they're doing amazing work. So they're a great resource to know more about how to involve men in breastfeeding, especially with the Black community.
I'll add a little bit to that as well. It goes back to the visibility piece. And so if you think it's hard to Google or see on social media pictures of Black moms breastfeeding, imagine like seeing a Black mom breastfeeding with her husband, supporting her by her side. I know a lot of organizations and folks are doing photo shoots and this and that for the mom and the baby to get some photos to bridge that gap, but also including the partners as well. How beautiful would that be, so that we see our Black men supporting their family unit with breastfeeding. And oftentimes it's not because they're not present. And this is men in general, they kind of just don't know what to do. Like, what can they do? And the truth is not too much with breastfeeding. You gotta just let the mom go in there and breastfeed all day. But there are different levels of support simply by being by her side and showing that it is a family unit. So I do think that we need to see more imagery of our men supporting their families, because they are, but they just step aside and let her take the spotlight, and just saying like, hey, come to this support group. I know when I was doing clinical hours, men did not think that they were welcome in the support group because there were women exposed, but that's not the case. And you would always see the one dad come in and you're like, look at him, like he was strong. But just even saying, hey, you are welcome here. This is also your space. And they'll say like, really? They simply just didn't know. So sometimes it's not even that deep. It's just that they don't know. So giving them the invitation to come in and be a part of the picture is really important.
Yes, and if I could also jump in and add a little bit to this question, I think in addition to what my colleagues have said, I think it also needs to be addressed prenatally. One of the things that I found particularly challenging during the pandemic is the fact that we didn't have dads coming to prenatal care visits. And you know, and many healthcare providers have still limited those support people being present. And and so with dads being present in the exam room, being offered the opportunity to ask questions. I mean, just as how Aqueelah and Tamesha talked about them being welcomed in the breastfeeding support group, they need to also be welcomed in the prenatal space, to know that they are going, and honor how that they are going through a pregnancy as well. And you also see it in the hospital. I'm trained as a home birth midwife, and so most of the births that I've attended have been in the home, where this is the dad's space. He feels completely comfortable. He can get in the bed with his partner. And he can walk out when he feels like I need a break. He can have his friends in the living room, and have his own support service there. And I always when we needed to transfer, to the hospital, I could see the dad like trying to find his spot, and so I think in the childbirth space, we also need to welcome dads into that space, welcome their support, allow them to cut the cord, allow them to catch the baby, make sure if they need to get in the bed and, to provide that support or, whatever, it just all of what you're saying, but throughout the entire process.
And I know we're probably, I just want to add one more thing, if that's okay.
Yeah, go ahead.
Because this is such an important topic, especially for the Black family, because we're so segregated, we're separated. The Black man has been removed from us, and they are really the center of our family, right? Like they're our covering, and so because they have been removed, it's to me, this is really an important topic. So I mentioned earlier about the answer being in the community, right? So we may have ideas about how we can incorporate dad into like education and support, but how about asking them? So think about that for a minute. Like maybe you should do a focus group with Black fathers and find out how are some ways that you can incorporate them in better in education. You might find some of the things we've shared to be, what you can do, but you also might find something specific to your community that would be important, right? So what do they need?
Yeah, well, I know,
Really
and
quickly, so
okay.
sorry, Dr. Taiwo. Someone had asked in the
no,
chat,
this
is gonna be more
I-
for Tamar. I don't want it to get lost in the chat, but they wanted to share a link to a survey. They're working on a grant, and I think it's really important for us to uplift and support each other's work. So I didn't want that to just filter through without us recognizing and acknowledging if it's okay to post that, because this is a pretty large group. And we're all trying to work towards reducing disparities and gaps. Okay.
Yeah, and perhaps Tamar, if you can actually send that link out to, if that could be sent to Tamar and she could send out, because we do have a few people who had to leave us a little early. So yeah, we would really like to see as many folks involved in that as possible. Yeah, I think all of us would love to talk for the next 20 minutes about the importance of and how we can incorporate Black fathers. But we do have to get to the other questions, because I have about 4 more things I wanted to say about that. We have a question here that I would like to take, and because it is the focus of my research, I have a couple of questions. One is, any study that examined the impact of ACE on the neurological and brain development function? And we also had a question, which I can't see right now. There was another effect of toxic stress during pregnancy. And Tamesha, I think you also addressed this in your presentation as well, so you can jump in. So I would like to, if I could, I have permission to share my screen very quickly. And it's easier for me to show this. So we have a number of pathways that stress. Are you guys seeing a slide with a pregnant belly? Okay. So Tamesha talked about epigenetic changes across multiple generations, and the how that happens, and so yes, it happens across through in utero, and both from the these processes of the microRNA expression, DNA methylation, and histone modifications, and so this is how, these are the pathways that Tamesha talked about, where the altered epigenetic regulation can influence at from the endocrine system, as well as brain development across generations. The thing that it's important to remember is that the fetal brain is what starts to develop first and continues to develop through infancy. So human babies are born premature in terms of our brain development. That's why there's this extended period of us needing care. And I think both speakers spoke to the importance of breastfeeding to continue that brain development. Like, breastfeeding actually helps grow neurons and throughout infancy. If human babies stayed in until their brains were fully developed, we wouldn't be able to get them out. And so that is why human babies are born premature, as opposed to other mammals who, you see horses, they get up and they run within the first few minutes of life. So that brain, that fetal brain is when the mother is under assault, that brain is under assault as well. And so you'll see that that dysregulation of that stress response system, all of those chemicals that are flooding the mother's body, that cortisol, those catecholamines, those pro-inflammatory cytokines, all of those are bombarding that fetus and its developing brain. And then we also have genes that can moderate or exacerbate stress reactivity. Why is one baby who's having the same, whose mother is having the same as another baby, and that baby's not affected, their brain is not affected? Maybe that one mom has some specific genes that actually help to tone down the effects of that toxic stress. And so that is why we will see, issues with executive functioning, with the ability to make these complex decisions. Working memory can be affected. So why is it that mother says to you that her child, I tell them this once, I tell them twice, and they do not remember it? Maybe they actually really don't remember it, because that working memory, that short-term memory, and those of us who are over 50 know how important it is, that short-term memory, and how frustrating it is when it leaves. Imagine that short-term memory is impacted in a 2-year-old because of the prenatal environment. So I hope that is a very brief, hope that is helpful to answering that question. And my co-speakers want to add anything to that?
No, that was great. That was really helpful. I know there's a lot of conversation and worry about that people have. How is my environment impacting my child when they are faced with so many stressors a day? I think about it all the time, like, what did I do to my children if I'm super stressed out? So this was a good overview and explanation.
Yeah, but I also need to remember to say, and I think I'm so glad you brought that up, Aqueelah, is that our brains are very plastic. And so there is, in a nurturing environment, there is the ability to really heal a lot of that. Okay, yeah, so thank you for that question. Thank you. We have 12 minutes for questions. We have a question: how do you successfully appeal to Black mothers in the community to take advantages of resources that appeal to them? I have run into resistance from the very group I seek to serve. I'm looking for root causes. Is it a good idea to ask them what aversions or barriers exist for them in regards to utilizing services?
I'll speak a little bit. So coming right out and saying that, you might be faced with more resistance. I think it's really important, if you want to work with them and support them, you have to build trust, right? You're not going to get trust, even for me as a Black female, I'm not going to automatically assume that you're going to trust me just because, right? So you always have to build rapport and show them that you legitimately do care, because there's so much distrust in the system already. And so if you don't have that connection with your community or your environment, then they're always going to be guarded or standoffish to receiving the information, because they're going to think that it's just, another part of the system.
Also, were you done, Aqueelah? I'm sorry. You were done?
Yeah, I was done. Oh, I will say one more thing. Sorry. Also, doing community events as well is really helpful with providing those resources. So it might not be a one-on-one type of interaction, but they can get that resources and support collectively. Black Breastfeeding Week is a great opportunity. I hope that every institution is doing something to acknowledge that week, along with the other breastfeeding weeks, whether you're putting up posters or banners or some type of support, giving a whatever you can give, something out to acknowledge the day and show that we are here, we hear you, we see you, and we're willing to do what it takes to bridge those gaps. So taking advantage of those type of opportunities for the community to engage with them directly, I think will be really impactful.
Absolutely. We also have a question from Maya, who said she would like to speak her question. Is it possible to allow her to speak? Or is Maya, I don't know if Maya is still here, and I didn't write down her last name, so I hope there's not more than one Maya.
I think it might be Maya Davis. Perhaps Tamar can unmute her.
Hi, can you all hear me?
Yes.
Yes, we can.
Uh-oh, can you hear me? Uh-oh.
Go ahead, Maya.
Oh, so my question was that when you all were speaking about there's more free access to formula than there is breastfeeding support. So I just finished the lactation consulting training, and I would like to know if you all have any resources about if there are ways to where Black mothers can get access to free or low cost lactation services from someone. Also, while that person can, you know, be able to make a living providing that service. Like, is there any type of subsidy programs that you all know of? Because I know sometimes with Medi-Cal, it's like, oh, if you're not licensed, like a doctor is, which there is no licensing program for consultants, it's hard to get payment. So how do we circumvent that problem?
That's kind of a good loaded question. In terms of the mother, depending on where she's located, I can only speak for LA County. That's all I know. And I know that you guys are everywhere. So here in LA County, our coalition task force has a resource guide. And in that resource online guide, it tells you who's providing free services that we look at. So perhaps even if you're looking for reaching out to providers, you might have to just see if some of them are offering free or low cost support to moms in need. In terms of access, you know, the Affordable Care Act does say that moms need to receive lactation services. As a lactation consultant, unfortunately, it's kind of no such thing as, you know, billing insurance directly outside of Aetna. And so we provide what's called a super bill. So we give them that bill, they take it back to their insurance providers for reimbursement, but you still have to pay for our services up front. Also, qualifies for WIC services because they're able to receive free lactation support if the agency has consultants or at their minimum certified lactation educators to support the mom. But that's the thing, you know, there's so much free formula circulating out there, and formula companies target specific zip codes and they will ship free formula. It will just wind up in your mail. Like, how did you even know I was pregnant? It will wind up at your doorstep because they're trying to hook you on formula versus breastfeeding your baby. So this is something that needs to be addressed, and it's clearly a gap. And that, unfortunately, I don't have like a better answer for that because it's a problem.
And I'll just kind of piggyback off what Aqueelah said. You know, and I'm in San Joaquin County, which is on the other side of the state, and we have the same problem. Like, we actually do have a breastfeeding resource guide, and majority of free services for lactation is through our WIC programs. Outside of that, so if you don't qualify for WIC or you're in that interim where you can't afford a lactation consultant, that's private practice, which honestly we only have like 2 in the county, and you don't qualify for WIC and you're in the middle of that, then what resources are there for you? There really aren't any. One way that Flourishing Families, my organization, is trying to fill that gap a little bit is we have partnership with the REACH of Stockton program, which is a REACH grant through the CDC. And so one of the things that we've actually done on that work plan is they've contracted with me as a consultant to provide direct support to women in the community. So they pay me to provide lactation support to Black mothers in the community. And so that's something like that. I mean, it's a small amount. It's not that much, but something like that, it replicated would be great, right? So then that way lactation consultants can get paid and women can receive free services. But that is absolutely a gap and a need. So I hope that helps answer your question and give our perspective on our side of the state.
Okay, good. Yes, thank you. We've got 5 minutes and 6 questions. We are, and 2 of them are, I can combine, helping mothers be okay with breastfeeding in public. A lot of moms will breastfeed, but then use a bottle when in public. And then also addressing the stigma, and even the stigma coming from partners. So if I could ask you to be very, very brief, that's another loaded one.
Can you
I
repeat
think
it
it
one
just
more
goes
time?
back
Oh.
to making it a norm. We have to normalize breastfeeding, right? There's no surefire way to make someone feel comfortable. You know, people are modest, it's their body. But if we normalize it and show that this is a natural thing and the optimal way to feed infants, whether it's on social media, on billboards, when you walk into the store, or just other moms doing it, is a great way for us to start taking down these barriers and just supporting the moms. If she wants to cover up in public, great. If she wants to be all out, great. And being there as a support system, if they need to come in and say, I faced this when I was shopping at the mall, and you encouraging them that it's okay, that's just their views, but continue to breastfeed your child.
Tamesha, did you want to add anything about reducing stigma?
So I'm sorry, I was trying to read what you had put in the chat. Can you just repeat it one more time for me?
Just
The question.
What tools can be used to address the stigma of breastfeeding in public?
Okay. What tools? I think that Aqueelah really did answer it by, normalizing it. I think that making it something that's not necessarily taboo or shamed, and meeting the moms where they're at with their comfort level. I absolutely agree with that. And know that it is okay, regardless, regardless of how you want to breastfeed in public, whether it be covered or not. But also making that a common precedence in like your safe spaces that you create. I mentioned earlier as well, like breastfeeding is welcome here. I know that some of the places that African Americans frequent, like the barbershops or even like the hair salons and places like that, I've had an idea for a while now that it would be great to make those spaces like breastfeeding friendly, or have them adopt, lactation policies in those spaces, so that they are aware, that this is something that is not only accepted but welcomed, and then it normalizes it in those spaces that they're already frequenting. If we're talking, already being frequent, and so if that makes sense.
Okay, yes, it does. I'm going to grab 2 questions. Someone asked about speaking to ensuring the safety of Black parents and babies when advocating for themselves, when asking questions of healthcare providers and being seen as a challenge, and CPS getting involved. And then also a question about is there a questionnaire to assess the mental health during doctor visits, and culturally competent questions to better assess trauma. So I think that's Aldisha Smith, and I don't know who the other person was, but I would encourage you to go to the website, thebirthplacelab.org, and I'll drop that in the chat. And we have done a study that looked at mistreatment among childbearing families, and we found that actually one in 7 women, childbearing women, suffer some form of mistreatment. And of course, Black women experience, the greatest amount of mistreatment. And that actually, even a white woman who has a Black partner, her rate of mistreatment actually approaches the rate of mistreatment for Black women, and any social risk factor increases mistreatment. So on the Birthplace Lab, in addition to that study, we also have some tools that have been developed. There's the Madam scale, which is autonomy, measures autonomy. And also there is the Mori scale, which is measures of respect index. And though you can use those tools and incorporate them into your into your practice. Those are tools that have specifically address you know, someone just, Felicia Bell just put in anti-Blackness. Yeah, that express anti-Blackness. And there's also a new, oh goodness, her name just left me, Patience. I can't remember the last name of this researcher, developed a perinatal discrimination scale. And I will send that to Tamar so she can send that out to everybody. So we have researchers of color that are actually developing the tools that can be used to address autonomy, respect, and racism in the healthcare environment. Oh, okay, so last question I think is, can we discuss challenging the race-neutral language of ACE's risk factor and actually naming racism as a risk factor? It has always troubled me that many of these risk factors are defined as health behaviors, as opposed to these things happening to marginalized groups because of anti-Black racism and white supremacy. Factors like having a parent who's in prison and losing a parent due to death. We know that racism is the root of those. I think Allison answered her question, but do you have any thoughts that you would like to share about that question, comment? I think, yeah, Allison, yes, it's part of our work. And I think those of us who are here are on that journey of making sure that we call it like it is. We live in a toxic soup of racism. We're all in it. Black nurses mistreat Black patients. Black doctors mistreat Black patients. Asian, you know, I mean, we're all in it. You know, it is not a Black-white issue, and it's your proximity to whiteness is what gets you good care, and the further away you are gets you bad care. Okay, so I'm getting nods. And oh, there is one more question. What contributes to the Asian community having the highest percentage of initiating a breastfeeding relationship with their babies? Can I take a stab at that, speakers? Okay, I would say, I don't know because I haven't studied that, but I have a comment. Number one, I think we have to be very careful to make sure we look at what our reference group is. And in the United States, our breastfeeding rates are abysmal. So I think the Asian community, I think their rates of breastfeeding at 6 months is around 80%, which we could say is good. It's better than, but wouldn't 95% be better? And so, so I can speak to, what we all can speak to is what works for anybody breastfeeding. Folks who have midwives, their breastfeeding rates are closer to 95%. People who have doulas, their breastfeeding rates get close to 100%. People who have access to lactation consultants, their breastfeeding rate increases. So perhaps I would say the Asian community, which we know that there's a problem with the Asian community, which includes everybody from the Pacific Islands to India, China, Japan. They don't consider themselves one people, but we know what helps everybody. And we just want to level the playing field. We want Black women to have the best care. And when we take care of Black women, we will take care of everybody, right? But and so I don't know if you want to add to that, to what I said.
No, I don't have a specific response for that as well. I did hear one before that someone had talked about, but off the top of my head, I don't. We can certainly look for some research on it, but statistically, they do have higher breastfeeding rates, duration, initiation, everything across the board. I don't know what the cultural has to do with it or level of support that they have, or just a history of breastfeeding. I'm not 100% sure, I don't really remember, but we can certainly look into it some more.
Yes, and we also know that immigrants breastfeed. You know, the longer you're here in the United States, so African immigrants breastfeed longer than African Americans. First generation Hispanic immigrants breastfeed longer than second generation Hispanic people. So, you know, it's also living in the United States and being a victim of racism. Yeah, and so so it's hard because to really address that question, but we are at time, and I'm going to hand things over back to Rhonda to close us out.
Okay, so thank you all so much for the amazing information that you shared today. Thank you for your insight, your wisdom, your passion, and doing the work that you do to make things better for Black women when it comes to breastfeeding and maternal health overall. So I want to thank the folks at WIC, Jasmine, Tamar. This would not have happened without you all coming together and stepping up to kind of the challenge and question I posed to you a few months ago. So I appreciate your partnership. I appreciate all the great work that you all do for the women that you work with. And hopefully we can continue to partner and do more things like this together going forward in 2022. So thanks again, and enjoy the rest of your Friday, and have a great weekend, everyone.
Thank you,
Bye.
everyone. Stay safe. Enjoy your weekend.
Thank you.